Hey everyone, let's dive right into this explainer on the absolute latest advances in modern anesthesia. We're pulling critical insights directly from recent clinical pharmacology webinars to build a rock-solid foundation for those of you joining us from the Anesthesia Learners Academy platform. The landscape of pharmacology is shifting incredibly fast, and what we used to know about these drugs is literally being rewritten right before our eyes. Here's our clinical roadmap for today. We're going to cover the modern anesthesia revolution, enter the world of soft drugs, navigate the diabetic drug dilemma, check out ketamine's surprising new tricks, and finally, look at why the future is titratable. Let's get to it.
Section 1. The Modern Anesthesia Revolution, a New Era of Precision. Moving right along to Section 2. Enter the soft drugs, rapid, predictable action.
So what exactly is a soft drug? Well, it's a completely revolutionary pharmacological concept. Think of soft drugs kind of like secret messages that literally self-destruct in the bloodstream the very second they've been read. They achieve their therapeutic effect, right? And then boom, they're rapidly chewed up by non-specific tissue esterases into completely non-toxic products. And the best part? Because this whole process is totally independent of liver or kidney function, we get incredibly rapid, predictable patient recovery, even if the patient has severe organ impairment. It's a total game changer. To put that into perspective, let's look at our traditional workhorse, propofol, compared to the new ultra-short-acting soft drug, remimazolam. Now, propofol has been a staple for us, sure, but it definitely comes with baggage, like cardiovascular depression and a pretty high incidence of injection pain. Nobody loves that. Remimazolam, on the other hand, gives us superior blood pressure stability and minimal to zero injection pain. And crucially, because it's a benzodiazepine derivative, it is fully reversible with flumazenil. That gives the anesthesiologist a massive, massive safety net. We see a really similar story when we compare standard fentanyl to remifentanil. Standard fentanyl relies heavily on the liver, clearing at about 1.5 liters per minute, and has a half-life of roughly 3 to 4 hours. That means it can accumulate pretty heavily during a long surgery. But remifentanil, it has a half-life of just 9 minutes. With tissue esterase clearance at 4 liters per minute, you get literally zero accumulation. It makes remifentanil an absolute dream for fast-tracking surgical recovery and having patients waking up in just minutes. All right, Section 3, the diabetic drug dilemma, surgical complications. Now, here's a critical question we really have to ask ourselves. Why are today's top diabetes drugs an absolute nightmare for anesthesiologists? I mean, these miraculous metabolic drugs are doing wonders for patients' day-to-day lives, for sure, but they are simultaneously creating hidden, genuinely life-threatening risks for those exact same patients the moment they go under the knife. The crucial point here is cleanly separating two very distinct threats. First up, we've got the massively popular GLP-1 agonists. The mechanism here severely delays gastric emptying, which creates a major, major risk of pulmonary aspiration. For these patients, we often need to withhold the medication or do a quick gastric ultrasound. Then, on the flip side, we have SGLT2 inhibitors. Because these cause high glucose excretion in the urine, they can trigger something called euglycemic diabetic ketoacidosis. Basically, the patient goes into a state of silent ketoacidosis and severe dehydration, even though their blood sugar levels look totally normal. It's super sneaky. The current recommendation? Discontinue those SGLTs a full 3 to 4 days before any elective surgery. Let's actually focus on that first risk for just a second, the fasting patient who still has a full stomach. Because GLP-1s delay gastric emptying so significantly, a patient who has diligently starved themselves for the required 8 to 12 hours, well, they might still have a stomach completely full of solid food. This makes routine induction highly, highly dangerous. It completely upends our traditional reliance on basic fasting protocols. For us assuming an empty stomach based purely on a ticking clock, yeah, that is no longer a safe bet at all. Okay, moving on to Section 4, ketamine's surprising new tricks, a modern renaissance. Ketamine has honestly undergone quite the evolution, right? It went from a rough battlefield anesthetic to a precise miracle tool. It was initially synthesized back in 1962 by Dr. Stevens, and it really gained fame in the 1970s for being rugged and easy to use in war zones, no refrigeration needed. But skip ahead to the 2000s, and we are witnessing a complete renaissance. We're talking psychiatric care, chronic pain management, and surprisingly, widespread use in modern neuro-ICUs. So what's driving this massive shift? Well, it's all about dosing. The modern uses of sub-anesthetic ketamine are surprisingly vast. Far from its old, somewhat feared reputation of raising brain pressure, we now know that sub-anesthetic ketamine actually decreases intracranial pressure. It protects the brain by inhibiting spreading cortical depolarizations during traumatic brain injuries. But beyond that, it's an incredible tool for opioid-sparing pain relief. It acts as a potent bronchodilator for severe asthma, and it has this truly groundbreaking ability to rapidly reverse suicidal ideation and major depressive disorders. It's doing incredible things. Finally, Section 5. The future is titratable. Precision in medicine. I love this quote here because it perfectly captures the essence of modern clinical pharmacology. Remifentanil has evolved from a simple anesthetic adjunct to the central pillar of modern anesthesia and critical care, allowing anesthesiologists to titrate in real time. We are firmly moving toward a world of precision medicine. With agents that clear the body in literally minutes, we can titrate their effects in absolute real time, responding to surgical stimulation second by second. However, total control definitely comes with a catch. We really have to talk about the OIH caveat, opioid-induced hyperalgesia. Because soft drugs like remifentanil wear off so incredibly fast, they can cause the body to paradoxically feel more pain the exact second the infusion stops. It creates this sudden, severe analgesic cliff for the patient right upon waking up, and we obviously want to avoid that. To prevent this pain cliff, anesthesiologists absolutely must follow a set of exact bridging steps before waking the patient. Step 1, start multimodal analgesia, things like NSAIDs or regional blocks, a good 15 to 20 minutes prior to stopping the infusion. Step 2, administer a longer-acting opioid bridge, like morphine or traditional fentanyl boluses. And Step 3, slowly taper down the remifentanil infusion rather than just abruptly turning it off. It's this beautifully choreographed sequence to ensure the patient has a completely soft landing. I'll leave you with this provocative thought. As we've seen today, as drugs become softer, more targeted, and instantly reversible, are we entering an era where surgical anesthesia is no longer a physiological hammer, but a perfectly tailored switch? Think about it. Understanding these pharmacological shifts doesn't just improve how we manage surgeries, it redefines the very boundaries of human recovery. Thanks for joining me for this explainer, and keep exploring these concepts.